We are recording the sessions, so the recording will be made
available. Can you hear me now, Amir?
Yes, I can hear you now.
Yeah, apologies, not quite sure why I flipped onto that, but anyway, here we go. Can I kind of check that the slides are in presenter mode?
We can see the slides and we can see you. Fantastic.
Perfect. Thank you very much, everybody, for your patience. And Amir, thank you, the rest of the team, for the kind invitation to be part of this excellent masterclass. So we've got a relatively short time this afternoon, but what I'm hoping to do is to give everybody a feel about where this field, primary aldosteronism, is moving in 2024. I think it's very exciting. I think there's lots of developments coming, and I think it's a watch this space place. So I'm going to begin by just declaring my disclosures, as you can see. So I think one of the problems with primary aldosteronism is that a lot of people are obviously very aware of this, but actually there's a lot of legacy that we need to address, which means that perhaps we're not giving it quite the attention that we should do. So probably the first of those is the false perceptions. You only need to go back as far as 2008 to a very well-renowned medical textbook that declares that Conn syndrome is a very rare cause of hypertension. But here is a famous saying from the third US president, Thomas Jefferson: "He who knows nothing is closer to the truth than he whose mind is filled with falsehoods and errors." And this is definitely, I'm afraid, a falsehood. Perhaps that thought from Thomas Jefferson might play in the mind of one or two candidates for the presidency coming forward. Anyway, moving on, the other big problem I think for us is that this still has a surprisingly low profile in the majority of guidelines that those who are looking after patients with hypertension are likely to refer to. So you can see all of these esteemed societies with their relatively recent guidelines, and yet there's often very surprisingly little mention about primary aldosteronism. That's in quite stark contrast to if you look at the Endocrine Society guidelines, which obviously are focused on this disorder. Another problem is that often it's just too difficult to really sort everything out. And for the non-expert, it really can feel that way. Who should I screen? Should it be everybody with hypertension at presentation? What do I do if I meet somebody on medication? Which ones do I need to discontinue? Do I actually need to do a confirmatory test? If so, which one? What happens if the adrenal imaging in a confirmed case looks to be entirely normal? But also we need to be aware of the prospect of an incidentalomer confusing us. And then there's the age-old problem of whether we have reliable access to AVS. And I'm afraid that's still not the case in many, many centres. And then another big problem, I think, is that we often focus at a single time point on trying to make a decision as to whether a patient is a surgical candidate or not. But if you have unilateral disease, we say, okay, you could be considered for surgery. But if you have bilateral disease, here you go, here's your medication, off you go, and this is likely to be lifelong therapy. And I think we now need to start thinking in different ways about these patients. So you don't need me to remind you that from what I've just been saying, PA is much more common. And in fact, it's the commonest curable secondary cause of hypertension. And depending on which series you look at, it might account for somewhere between 5 and 14% of all unselected patients, and as many as a quarter of those with resistant hypertension. So we're really at the moment looking at the tip of the iceberg. I always cite this study, which I think is a really nice study from Anand Vaidya and colleagues, essentially just revealing the true extent of primary aldosteronism. This was actually data coming from 4 US study sites, 5 different protocols, patients with spectrums of blood pressure, including, you will see, individuals who had actually normotension. And these individuals all had aldosterone-renin ratios measured. And in those with suppressed renins, whilst on oral sodium loading, 24-hour urinary aldosterone levels were assessed. And using the threshold of 12 micrograms for 24 hours, you can see that in every group, but increasing as you go through increasing degrees of hypertension, you can see there is the presence of individuals who appear to have autonomous aldosterone production. And long story short, that translates into a significant number of individuals. Perhaps almost most alarming here are those who technically aren't actually with hypertension. But this is a significant burden of disease. And the reason it's important is pretty much when you match patients with primary aldosteronism to those with essential hypertension for comparable blood pressure levels, for all cardiovascular outcomes, but in particular here for this nice study, stroke, coronary artery disease, atrial fibrillation, and heart failure, we can see that the patients with primary aldosteronism are doing worse on each account, as shown by their deflection to the right as you're looking at it on the forest plot. So this is not a condition, I would argue, that we should overlook or treat lightly. So what I'm going to do in the next or remaining part is hopefully give you some insights into some of the emerging strategies which are looking to address the current shortfalls in clinical practice. This is taken from an article that we published just recently in Endocrine Reviews. In essence, it highlights the frequency of primary aldosteronism, but the fact that we've got multiple roadblocks in being able to get patients from one end of the pathway through to a definitive treatment decision, for example, be that surgery or not. And today I don't have time to go into all the novel advances that are coming, but I just want to highlight these for reference for you to go away and perhaps look at more. And then I'll pick out some examples of some developments that we've been involved in collaboration with many, including colleagues at Imperial. So first off, the diagnosis, I think, is one where we still have a huge challenge. If we don't think about the diagnosis or we don't know how to do the interpretation, then we're less likely to actually set somebody off on this pathway. And I'm not going to spend too much time focusing on this today. And indeed, the next speaker, Vipkarl, would be better equipped to talk about the potential that we can get out of measuring steroids and indeed many other factors and considering, for example, metabolomics and machine learning to allow us to actually start to pick people who do not perhaps necessarily meet barn door criteria for a diagnosis of PA, but in whom it would be nice to find them sooner rather than later so we can start to mitigate the risks of accumulating cardiovascular damage. One of the other big challenges we all know is tumour localization. I've already highlighted issues around AVS, and I'll briefly speak about the work that we and others have done in trying to increase the chance that if there is a lesion, we can find it. We're going to hear from another speaker later on, from Fausto Palazzo, who's one of the world's leading adrenal surgeons, and he's going to tell us about surgery itself. But actually, increasingly, we're starting to think about whether surgery should be complemented by other techniques, such as, for example, selective nodule targeting, be that either surgically, which has its challenges, or, for example, through ablation approaches. And then today, I won't have time, I'm afraid, to highlight the exciting or to go through the exciting changes which are coming in pharmacotherapy here. But I think watch this space for the new non-steroidal mineralocorticoid receptor antagonists and also the aldosterone synthase inhibitors. This will definitely give us better pharmacological tools to treat this condition. So I'm actually going to focus for a little bit now, for a couple of minutes, on molecular imaging as an alternative to adrenal vein sampling. Everybody will be aware of the conventional pathway nicely captured in the Endocrine Society guidelines for how a patient goes from a diagnosis through imaging, through adrenal vein sampling, if they have unilateral disease, to laparoscopic adrenalectomy. But I've already mentioned there are multiple roadblocks here, either because people don't think about the diagnosis, or they get stuck, or they can't access reliable AVS, or even actually trying to work out who it is that we should think about actually sending for surgery because they're going to do better than the next person that we could send for surgery. And we all know there's this enormous bottleneck around AVS and the fact that many patients simply don't get that decision because they cannot be deemed to have, for example, unilateral disease. Now, others have thought about how to potentially tackle this, not through just AVS, but also even trying to look at the possibility that we might be able to be very, very selective in what we do to the adrenal, even using AVS, by performing super selective AVS. So that means not just cannulating the adrenal vein, but actually getting into the individual, as it were, tributaries here. And there is some beautiful data on this published, but I have to say that it's very tricky to imagine anytime soon we're going to be in this position, given that in many centres still, there is still a low success in just cannulating the main adrenal vein, never mind getting into the branches, as it were. But actually, the whole concept of that super selective AVS a little while ago had got us thinking about are there other ways in which we can find offending lesions. And a long story short, Maurice Brown and I, back in 2008, 2009, decided to look at deploying a tracer 11 carbon metomidate. So you'll recognize metomidate as being actually a drug very closely related to the anesthetic agent etomidate. But this molecule can be nicely tagged with 11 carbon, so it can be used as a PET tracer, and it binds very avidly to CYP11B1 and CYP11B2. Now, actual fact, we need to turn this tracer into a B2 selective ligand because, of course, it's the B2 enzyme, aldosterone synthase, which is overexpressed in primary aldosteronism in the adenomas and nodules. And you can see that if we perform PET as shown in the middle column here, without dexamethasone suppression, we see uptake not only in a nodule, which is this tiny little nodule in the lateral limb of the adrenal, but also in the heart of the adrenal. But if we give 3 days of dexamethasone to suppress the expression of CYP11B1, 11-beta hydroxylase, we see that we can then actually see the nodule much more clearly. And that's actually a cornerstone of this technique. You turn this tracer into a selective B2 tracer through the pre-application of dexamethasone. And I'm just going to show you some images from that paper, which amazingly is now way over a decade old, showing patients with unilateral PA as defined by adrenal vein sampling, and those with bilateral PA as defined by adrenal vein sampling. And I hope I can persuade you that not only does the PET look a viable alternative to the AVS, but actually now we can not just talk about lateralizing, we can truly talk about localizing. We can actually tell you which nodule in an adrenal gland is the offending cause. So if you like, aspiring to achieve the same as might be done through superselective AVS. And this allowed us to detect lesions, as you'll appreciate, in this small little lesion on the lateral limb in the unilateral case on the bottom there, really pinpointing the cause. I'm delighted to say that many others have gone on to do this, and I've literally just picked out one study from Troy Poor and colleagues working in Singapore, published again very recently in a prospective trial taking 28 patients who underwent AVS and metomidate. Remarkable success of AVS, 100%, really impressive this. And I think one important thing that this study highlighted immediately is that AVS and metomidate don't always find the same patients. So you'll see that in half the patients, or just over half, who were unilateral at the end, is only in half of those that we got this agreement between them. And in some cases, the PET identified unilateral. In a lesser number of cases, that it was the AVS that said unilateral when the PET said bilateral. And the good news was that these patients actually went through to diagnostic criteria being met by having surgery and had a complete biochemical success rate, i.e. reversal of the abnormality of the aldosterone-renin ratio, desuppression of the renin, etc. So it's not as if you're actually sending the wrong patients to surgery, you're definitely sending the right patients to surgery. And this led this team to speculate that perhaps it's time to move molecular imaging to the top of the algorithm, because when it says unilateral, virtually always it was correct in this study. And if it said bilateral, it was then worth thinking, if you thought the patient really was a candidate for surgery and you felt for some reason maybe the PET wasn't picking it as unilateral, then to think about AVS, because there were 1 or 2 extra patients who made it on that route. Now, while this study was going on and being reported, together with the Barts team, the Cambridge team, and also working actually collaboratively again with Vipka and colleagues when Vipka was in Birmingham, etc., undertook the MATCH clinical trial. The MATCH clinical trial, when we designed it, was to see whether this was a technique that was superior to adrenal vein sampling. This is sponsored by the NIHR. It was a simple study design in that every patient came in was randomized to have both investigations, MTO and AVS, in random sequence, and then they went on to a trial of spironolactone before going to surgery if they had unilateral disease or stay on medical management for bilateral disease. I won't go into enormous detail, but we used a co-primary hierarchical endpoint system, which means that you start with the lowest threshold to achieve. Do you achieve partial or complete biochemical success? If that's significant, then you can progress to the next stage. Do you achieve complete biochemical success? And then through to that partial or complete clinical success as judged by blood pressure, or complete clinical success. 224 patients screened, and again, in the interest of time, I won't take you through everything, but the patients who then actually came into the study for full analysis after exclusions or those withdrawing were 143, about a third of the way down there. All patients then through the MDT, very rigorous analysis of the data, all the PET scans analysed totally blind to the AVS, and then a decision taken as to whether the patient met the criteria for unilateral disease and surgery. And any form of unilateral disease, either on PET or on AVS, got you to surgery. The only thing that stopped you is if they were discordant with each other. Long story short, just as we'd seen just now in the Troy Poor paper, there were patients where both investigations identified unilateral, and patients significantly where only one investigation identified the patient have unilateral. And you can see this again now represented by the proportion of patients achieving biochemical success, partial or complete, and then clinical success, partial or complete, depending on whether they went to surgery on the basis of both investigations in the purpley colour, the MTO alone in that slightly orange colour, or the AVS alone on the green. The important message from this study is that the PET-CT, although not superior to AVS, was certainly non-inferior. And in fact, as you can see, not only did it come in comfortably inside the non-inferiority margin, but actually the majority of patients, in the majority of the, or indeed all the outcomes, there was a trend, albeit obviously not significant, but a trend towards the PET-CT being more accurate. You can see that when the patients went to surgery, it wasn't a case that we sent patients to surgery who didn't get benefit, because here is the plasma aldosterone in the patients having surgery in blue versus those on optimized medical therapy. You can see beautiful desuppression of the renin in blue compared to the medicine patients, and you can see reversal of the AR ratio. You can also see more significant improvements in blood pressure in the surgical arm, although it's fair to say that the medicine arm was not regimentally followed in terms it was left to the local clinicians to titrate treatment. This study also gave us a really nice little insight into which patients might do best from surgery. First off, the younger patients generally tended to be more likely to achieve a complete clinical response, i.e. normalization of blood pressure on no treatment afterwards, than the older patients. Not a surprise to many of us. What was very interesting is that there was a definite tendency for female patients to be more likely to achieve complete remission. We also saw some interesting observations in the spironolactone trial, and again, in the interests of time, what I'll show you is that if you had a trial of spironolactone, just literally 4 weeks of spironolactone, you were likely to achieve normalization or complete remission after surgery further down the line if on the spironolactone during that trial you got a systolic blood pressure less than 135. We also looked at the different somatic mutations that were present in the tumors. This is beautiful work done by Morris and the team at Barts. And then what we were able to show is that if you actually carry a somatic mutation in the inward rectifying potassium channel KCNJ5, you are much more likely to achieve complete remission of clinically, i.e. blood pressure control, than if you had other mutations, such as the other most common mutation in a calcium channel. And through lovely collaboration with Vibke and Alessandro, we had a nice demonstration that the hybrid steroid 18-hydroxycortisol to cortisol ratio, which is increased in individuals with KCNJ5, actually was allowing us to even potentially pick these patients ahead of surgery. And in fact, really remarkable separation with just one ATP 1A1 patient, actually, as it were, interfered with almost 100% separation there. And this again just shows you how selective this tracer is. Here's a patient with 2 nodules in the adrenal. You can see on the left that that's hot, whereas on the right it's not. And the beauty is that it's the CYP11B2 nodule in this patient with 2 nodules, one expressing CYP11B1. It's the B2 that detects the tracer. Now, I'm conscious of time, but what we'd really like to propose at this stage is PET-CT now changes the algorithm and gives you an alternative to AVS to get you through to laparoscopic adrenalectomy. The problem with 11-carbon-methionine PET-CT is the availability of the tracer. So we've done a lot of work to try and now find a tracer which is 18F fluorinated, and CETO is a relation of metomidate and etomidate. What's really nice about CETO is it shows very, very selective uptake in the adrenals and much lower uptake in the other organs. So here on the right-hand side, we can see little liver uptake compared to metomidate. And long story short, having conducted a first-in-human study to prove that this tracer is completely safe, we were able to demonstrate that actually, just as we had done with MTO previously, in a patient with unilateral PA, if we pre-treat with dexamethasone, which is this column here, where the yellow arrow here is the adenoma is visible, whereas the background uptake in the normal adrenal on the right has been suppressed, and you wouldn't have told the difference without dexamethasone. But in a patient with bilateral disease, that dexamethasone treatment does not result in a false positive. So we've taken patients such as this patient here, and I'm showing you both the metomidate and the CETO, and I hope I can persuade you that the images from the CETO are almost identical to the MTO, but with this huge benefit of no tracer uptake of the MTO. And again, here's another patient where you can see multiple slices on an MTO scan showing uptake that you can't see any difference really compared with the 18F CETO. So these tracers are almost identical to each other. And this has got us very excited about a study which is now running, again, Barts, Cambridge, UCL, Imperial, and Sheffield, where we're now looking to see whether we can use this molecular imaging to target ablation of nodules specifically because we know exactly where they are. So this is PET-guided radio frequency ablation, but we're also looking at microwave ablation. And the novel thing about this is that the way in which we have previously performed a study, which is now being prepared for publication, is to deliver that ablation endoscopically. So you can actually approach the left adrenal because it's just posterior to the stomach, using the endoscope, using ultrasound to be able to visualize it, and then literally poking the radio frequency probe or the microwave probe through the posterior wall of the stomach into the APA to ablate. This is safe, and we had no major consequences of this in a trial of 30 patients or 30 ablations, and we're now forward into a new study where we're actually looking to see whether we can ablate not just a lesion on the left, such as this is a 3D reconstruction of one of our cases, but also to do percutaneous ablations for patients with lesions on the right. And I just want to really finish by showing you this case. This is a patient of mine who had a hot spot that you can see on the metomodate that beautifully correlated with the nodule. And you can see that after my endoscopic interventional radiologist, Ed Godfrey, has been in there, he has ablated that beautifully so that the nodule is still visible, but now there is no uptake of metomodate. And this beautifully correlates with this patient having normal blood pressure and normal biochemistry off all treatment. So I will conclude, Amber, if I can, by saying this is an exciting time for primary aldosteronism. I think we really now have an option to make a big difference to an awful lot of patients. I haven't had time to talk about how we can improve the diagnostics and find the patients more effectively, but I hope I have persuaded everybody that it's important to do this because we have many, many more tools available now so that we can actually find the lesions. We can actually hopefully find the patients with the lesions who are likely to benefit most from surgery. But we also now have an options for patients who might never have had an option for treatment previously because they couldn't have a unilateral adrenalectomy, either medical grounds, or maybe they've got bilateral disease, I'm speculating going forward, where we can use these alternative techniques. This slide alone tells you that I'm very fortunate to represent this enormous group who've done all this research. And you'll see a number of the people on this program today who are here and mentioned. I just need to acknowledge them, all the funders without whom we wouldn't be able to do this, and critically the patients and the referring clinicians. Thank you very much for your attention. I'd be delighted to try and answer any questions.
Thank you ever so much for that state-of-the-art overview of investigation of primary aldosteronism. Can I just quickly ask, perhaps we will follow this up in the next talk, the availability of 18-hydroxycortisol to cortisol ratio, which sounds quite exciting.
Yeah, I think it is. So again, Vibke will be best able to comment on that because I think we need something which is going to be available in a timely fashion. And I think one of the interesting things which I'd be interested to hear Vibke comment on is whether we will be doing this exclusively in urine, Amir, or whether actually we'll get to a point where we actually have an option for doing this in a blood test. Because essentially we need something which is accessible, but actually, as I think I've shown you, this really could be quite transformative because it could allow us to sift off a whole group of patients who do not need to go through invasive procedures to be able to proceed through to surgery. But at the moment, you are definitely going to have to refer the patients to one of the centres that does steroid profiling.
Thank you. You do welcome again to the 596 participants. You do not need to type in your emails or names. At the end, we'll show you a link and a QR code for the CPD, so you do not need to type in your name. But very quickly, just go through some quick questions, Professor Gunnell. Any relationship between serum markers like potassium, renin, and aldosterone and chance for PET activity?
Really good question, because there is data which actually shows that, for example, classic Conn's adenomas often are the ones with the more profound hypokalemia. And so there is some correlation between what you are likely to find on PET with that. If you've got a patient with profound hypokalemia, we often do find unilateral disease on the imaging, but you don't need to have hypokalemia to find it. So we can find unilateral disease. I think I've just shown you that actually what's fascinating here is we don't really understand PA because now we've got patients coming up unilateral on one test and not the other. And some people need both.
Absolutely. And a similar question, does baseline aldosterone influence the need for intervention?
Now that's a really good question as well. And the thing I'd probably highlight on that is that actually, we have a number of patients that if the aldo is really high, these patients do not do very well at all. And actually, although I wouldn't recommend this as routine practice by any stretch, these are the small number of patients where you might even consider intervention when you've got bilateral disease, which is why we're so excited about the development of being able to ablate nodules, because I've got a couple of patients with really terrible cardiovascular complications who we ended up doing a procedure unilaterally for the dominant side despite bilateral because they were in such a desperate place, and they've done spectacularly well. Now, I'm not recommending that that's routine clinical practice, but I think it speaks to very high aldosterone levels having very adverse effects cardiovascularly.
Thank you. I'm going to skip the question about surge adrenalectomy because we'll come on to that in Professor Palazzo's talk. Could you briefly explain the rationale for pre-treatment with dexamethasone?
Yes, apologies, I went past that too quickly. In essence, this tracer is able to bind both CYP11B1 and B2, which are obviously very close to each other structurally. And so in order to turn the tracers metomidate and ceto into B2 searching, finding tracers, the dexamethasone pre-treatment for 3 days suppresses the CYP11B1 expression. So you turn a B1, B2 tracer into a B2 selective tracer.
You no longer see the 11B1.
You see some B1, there's no doubt you see some of it, but you definitely drop the background level significantly, which is the big difference for being able to find some of the nodules.
Fantastic. Thank you so much. I think in the interest of time, we'll move on to the next speaker. I'm really grateful for your time and for your fantastic overview of it in 2024. Thank you. Next, we have got Professor Wiebke Alt, and we're absolutely delighted that Professor Alt joined us at Imperial College London, and she's the Director of Medical Research Council, Laboratory of Medical Sciences, MRC LMS. And as many of you know, she's made an outstanding contribution to our understanding of adrenal endocrinology, and she'll be talking about management of congenital adrenal hyperplasia. Professor Alt, over to you.
Excellent. Many thanks, Amir. Can you see my screen? That's a question now. I tried to share.
Yes, we can see your first slide and we can hear you very well.
Excellent. Great. I have also my camera on. That's great. And just to follow up on Mark's question on the 18-hydroxy and 18-oxo THF and so on. So partly this can also be measured in serum, but obviously we are in the process of systematically comparing this in a very large cohort. And but obviously measuring this in spot urine is super convenient. Then the patients even don't need a needle prick, but can just like, it's not necessary to have a 24-hour urine for this. So it's quite convenient. And we hope that this will be available within the next year or so. Okay, cool. I'm talking today about management of congenital adrenal hyperplasia, so slight gear shift. So, and I will focus in this on 21-hydroxylase deficiency, which you will know that this is the most prevalent form, more than 95, in some regions, 99% of all congenital adrenal hyperplasia variants. And what's happening in 21-hydroxylase deficiency, the HbA axis is modulated by the fact that the 21-hydroxylase enzyme in the adrenal is not functional. So if there are mutations in the CYP21A2 gene, then the function of 21-hydroxylase is disrupted. There's not enough production of glucocorticoid, and therefore a diminished feedback to the hypothalamus and the pituitary, resulting in an increased ACTH drive. But obviously the adrenals can still not produce glucocorticoid, but are stimulated all the time by ACTH, which results in adrenal androgen excess, and then consequently in virilization already of the unborn and hyperplasia of the adrenal gland, which gave the condition its name. So in principle, to just very briefly touch about it, this is adrenal steroidogenesis, and obviously there are several CAH variants that could occur in any block and branch point, not only 21-hydroxylase as indicated here, but also 11-hydroxylase, 17-20-lyase or 17-alpha-hydroxylase deficiency, 3-beta-HSD deficiency, and P450 oxidoreductase deficiency. Yeah, but in the talk today, I will focus on 21-hydroxylase deficiency. If you have a block in this enzyme, then you have diminished glucocorticoid activity. And if it's a significant block, a severe mutation, then you will also have mineralocorticoid deficiency. As discussed, this leads to stimulation of adrenal androgen excess and consequently 46XX disordered sex development. So that means females virilize genitally. And the marker steroid is a steroid that is accumulating in front of the block with 17-hydroxyprogesterone. So I show you here this, the sheets we always use to explain this to the patients, because it's extremely important for the patients to understand why they need to take their medication. Yeah, and so basically, let me just go back. We tell them the adrenal is nothing else than a motorway system of little cholesterol cars driving to their targets, aldosterone, cortisol, and DHEA. And basically, if you have a block at junction 21, all the cholesterol cars are redirected to the sex hormones, but we don't have enough aldosterone and cortisol. Yeah, and the idea is obviously that if we give exogenous glucocorticoids as treatment, we downregulate the ACTH drive. It's important to know that there is more than only the classic androgen pathway I've just been talked about, where DHEA and androstenedione produced in the adrenal are converted in the periphery to testosterone and 5-alpha dihydrotestosterone, which stimulate the androgen receptor. We know for a few years now, but it's not generally well known, that actually in the adrenal, androstenedione can be converted by the glucocorticoid synthesis enzyme 11-beta-hydroxylase to 11-hydroxyandrostenedione. Biochemically, we know this for decades, and we always thought that 11-hydroxyandrostenedione is some dead-end metabolites. But a few years ago only, it was shown that this metabolite can be activated to 11-ketotestosterone, 11-KT, and that 11-KT actually activates the androgen receptor with similar potency to testosterone. Yeah, this was first shown by young South African biochemist Karl Storbeck, and this is called the 11-oxygenated androgen pathway, as opposed to the classic androgen pathway. And this is really important, and subsequent research has shown that the 11-oxygenated androgen pathway is highly activated in patients with CAH. And there's also an additional pathway I don't tell details about, the alternative pathway to dihydrotestosterone, which is augmented in particular in patients with P450 oxidoreductase deficiency, and which can be switched on again in 21-hydroxylase deficiency patients before birth and after birth if biochemical control is poor. So that makes it clear that you have 3 different androgen pathways that can produce potent androgens that activate the androgen receptor, and this is the case in CAH. So if we have too much androgens, as I told you, we get disordered sex development, and depending on the amount of androgens, in dependence of the severity of mutation, there can be an external, almost complete virilization. Yeah. So obviously, normally at birth, we see baby boy and baby girl, and we are immediately clear about it. But in CAH, we are often confronted with ambiguous genitalia, where it needs chromosome analysis, karyotype analysis to come up with a solution. This is obviously a pediatric emergency, and if a girl is not treated, then she would continue to virilize and have like a male phenotype, like in this historic case from 1971. So in principle, there are 3 severity forms of CAH. So there is what we call classic CAH, which used to be called salt wasting, where you have both glucocorticoid and mineralocorticoid deficiency. Then we have somewhat milder mutation, but where you still have pronounced glucocorticoid deficiency, while not so much mineralocorticoid deficiency. And then you have milder mutation, what we call non-classic CAH, which can in its clinical presentation resemble polycystic ovary syndrome, because often these women primarily present in early adulthood with hirsutism and irregular menstrual bleeding. Yeah, and in these patients, there is not severe glucocorticoid deficiency, but they can fail the ACTH test, the short synaxin test, and there is a debate about whether they should take glucocorticoids in pregnancy. So when we treat CAH, we totally need to recognize that this is a balancing act. We need to give out exogenous cortisol to signal back to the hypothalamus and pituitary that they can stop sending lots of ACTH down, and that helps control the androgen excess. Yeah, but if we give too much cortisol, then we have metabolic side effects and we can suppress things too much. So it is important for us when we think about of how we replace cortisol to have in mind that obviously physiologically, and this is like a monumental paper from 1991 showing this with very good methodology, that cortisol secretion rates are different at different times of the day. And that we usually have a switch on of cortisol production in the early morning hours and peak production in the morning, while we then have very low production levels in the evening or around midnight. So, and here lies the problem, because with conventional hydrocortisone, we just generate these sudden peaks and troughs, but we cannot mimic the physiological cortisol rhythm. And in particular, we cannot mimic the early increase, the early morning hours increase that is, if unopposed, can drive ACTH and adrenal androgen excess. So therefore, Richard Ross, and I had the total pleasure to work with him and Miguel de Bono and Martin Whittaker on this for many years, has developed a modified, delayed and prolonged release hydrocortisone preparation that can be taken in a toothbrush regimen before you go to bed, and it only starts to release from your colon a few hours later. And then you take a smaller dose again in the morning that starts to release during the day. And so this is a special makeup so that this drug doesn't release immediately, but only after several hours. And with this, it is really possible to mimic the normal diurnal rhythm. And we studied this in collaboration with Richard by asking patients to collect urines overnight, during the day, and from the afternoon to late evening, and analyze their steroid output to see how do the 3 different pathways react to treatment with this drug. And that's shown here. Yeah, like this drug is called Chronocort or F-cortisol. And you can see here, these are patients that are untreated and controlled patients. And then you have patients, CAH patients on hydrocortisone, on prednisolone, on dexamethasone. And you see that you achieve the best control with this drug that mimics diurnal rhythm, while with immediate release hydrocortisone, your 11-oxygenated pathway and your alternative DHT pathway, as well as your classic pathway, is much higher. You achieve similar control with prednisolone and dexamethasone, which are obviously much more powerful glucocorticoids. But for this, you have to pay then with metabolic side effects, which can be a problem depending on the dose. Yeah. So like in the UK Chase, and I tell you a little bit about this study in a minute, it has been shown that patients who are on long-acting dexamethasone, that they have the highest degree of insulin resistance. So balancing cortisol and adrenal androgens is a key issue here. There are also additional therapy approaches that are investigated right now. Steroidogenesis inhibitors like abiraterone, a 17-hydroxylase inhibitor, has been examined, and there are several studies going on CAH receptor antagonists to achieve a downregulation of the HPA axis. And here, one item I wanted to bring in here is the possibility of adrenal crisis. So this is a clinical case, and I was called to see this man on the intensive care unit. This was a patient who was psychiatric inpatient for schizophrenia, and he was in a very poor state. And despite being young, he required intubation and mechanical ventilation. He had sepsis with pneumonia, and I was called to look at him. And he got a CT, which showed actually that he not only had right-sided pneumonia, but also bilateral swelling of both adrenals, like as shown here. So clearly congenital adrenal hyperplasia, and that was also confirmed by his biochemistry with his 17-hydroxyprogesterone sky high. His baseline cortisol was 470, and you may tell me, oh, that's normal. No, but it's not for a patient who's intubated on intensive care. So that's definitely a patient who can only mount an insufficient cortisol response to stress. And 1 month after he recovered and was on a normal ward, he narrowly passed the short Synexin test, and his genotype actually showed that he was a non-classic CAH patient. But that importantly illustrates that non-classic CAH patients also require assessment of the adrenal axis. All CAH patients require this, and they will need information on how to act when they are severely ill. Yeah, so this is very important. And this is a paper from Nicole Reich, who has examined what are causes of adrenal crisis in CAH, and these are mostly infections of the respiratory tract or the gastrointestinal tract. Also, an important insight we got in recent years is it was previously thought that CAH patients wouldn't have adrenal crises as often as Addison patients. But that's actually not true. These patients only report them less frequently. So it's really important that you inform patients with CAH that they can suffer an adrenal crisis and tell them how to act. We call this the sick day rules. We say if you have fever, infection requiring an antibiotics, or you have to undergo a small surgical procedure, we would like you to double your glucocorticoid dose. And if you have major surgery, trauma, vomiting, if you are prepared for colonoscopy, then you need an infusion, ideally, of 200 milligrams hydrocortisone over 24 hours, or 4 times daily intramuscular injection of 50 milligrams. This is very important. If you have a very high glucocorticoid dose during this time, you can pause fludrocortisone. You always have to have in mind how your glucocorticoid dose impacts, because hydrocortisone has mineralocorticoid activity, and importantly, dexamethasone has no mineralocorticoid activity. So if you switch a patient with salt wasting CAH from hydrocortisone to dexamethasone without looking at his mineralocorticoids, he might drop into adrenal crisis. In the UK, we have this wonderful steroid emergency card, which is given out by the NHS, and which comes also with the advantage that it has a QR code where people actually can quickly scan and then are guided to the adrenal crisis information on the Society for Endocrinology website, where the emergency cards can also be downloaded. Yeah, we also have several language versions for that. So this is really important. You need to give patients an emergency card. You need to tell them how to act in case of such an emergency. And ideally, they should have a hydrocortisone emergency self-injection kit, and importantly, should be trained in its use. UK Chase is important to mention. Richard Ross was my partner in crime for this, which was a very large study where we tried to bring together all CAH patients in the UK under specialist endocrine treatment. And I want to show you one further slide on this. And this actually illustrates that in endocrine specialist centers in the UK, there is only an absolute minority of patients as compared in gray here to the expected number of CAH patients in the respective age groups. So many patients, unfortunately, are not under endocrinologist treatment. They might be under GP. They might receive no medical care at all. This is something where we need to jointly look together to change this. Then 2 more items, and then I'll end. This is from my colleague John Bevan, a case he saw, and this is really important. This patient presented, and the history showed that he had CAH. And you see this, his left adrenal is 5.2 kilograms and his right adrenal 780 grams. Normally the adrenal is obviously only 10 grams. And these are giant bilateral adrenomyelolipomas. And poorly controlled patients with poor biochemical controls are more prone to this. And larger studies from Scandinavia have shown that we really need to watch out for this. So patients who have been lost to follow-up and come back into care warrant to have a CT adrenals done just to see what their state is. The experience with those is if they exceed 8 centimeters in diameter, they will continue to grow and then compress, though they are benign otherwise. And final word on fertility. Obviously, again, too much glucocorticoid and enough glucocorticoid, not enough glucocorticoids can have opposite but both adverse effects on female fertility. Yeah, it's difficult to get a baby under these circumstances. So it's really important that women with CAH are referred to specialists who look after this. in particular if they desire pregnancy. There should be partner testing, and there can be fetal DNA testing now in circulating blood to confirm sex and also mutation study status. And prenatal dexamethasone should be considered in female fetuses at risk of CAH. And Nicole Reich will lead now as a study that is about to start Europe-wide on the use of prenatal dexamethasone for treatment of CAH pregnancies. Similar for men, there are the so-called testicular adrenal rest tumors. I call them testicular adrenal rest tissue because they are not tumors, and hopefully people will not have their testicles removed. But the poorer the biochemical controls in males, the more this is present, and this can lead to fibrosis of the seminiferous tubules and abolish fertility if this is not reversed by better treatment control. So men should be made aware of this. It might be too late if they are discharged at 18 from pediatrics and come at 30 to become a father. And we can reverse this by short-term dexamethasone treatment. And also there are now excellent data from the modified and delayed release hydrocortisone that they can improve this. But please do not cut off the testicles. This is important. And the final slide, very importantly, we need a multi-specialist team to work together. A multidisciplinary management is critical, and the patient needs to be identified, informed, and empowered. We need to avoid that they have adrenal crisis and develop metabolic complications, which are prevalent. And we need to preserve their fertility, quality of life, and bone density. Many thanks.
Thank you ever so much for that very clear and comprehensive presentation, Rutger. Can I just ask you, you mentioned screening for TART. What is the best way of screening?
So the screening for TART is the best way is actually ultrasound. The most sensitive way is MRI. Importantly, manual examination will not help so much. You will only really palpate them if they are larger. So it's recommended to do ultrasound, and the pediatricians now recommend on data accumulated by Heidi Klaasen van der Grinten that this should start already in early adolescence to make them aware before they get out of pediatric care if there's a problem or not. And it seems to be coupled to poor biochemical control and severe phenotypes.
Thank you very much. What are the best markers for assessing patients with 21-hydroxylase deficiency, and what tools can we use to ascertain that they're on the correct dose of steroids?
Yes.
A practical question.
This is important. Like sort of if a patient is on conventional treatment, then you should aim that irrespective of it's men or women to have the androstenedione as a major adrenal output marker in the normal reference range for men or women, depending on what the patient is biologically. So on conventional treatment, you cannot normalize, you should not normalize 17-hydroxyprogesterone because it always will be high. So the target is to bring androstenedione into the normal range. We usually will also measure testosterone and the gonadotrophins because often these are suppressed if the patients are poorly controlled. But very interestingly, with modified and delayed release hydrocortisone, you can actually also completely normalize 17-hydroxyprogesterone without a suppression of androgens. So this is a very interesting phenomenon and might indicate that steroidogenesis changes over time when it's exposed to more physiologic replacement.
Thank you. So normal 17-hydroxyprogesterone on conventional treatment is over-treatment.
Yes, if I suppress 17-hydroxyprogesterone on conventional treatment, this is over-treatment. So important key marker is androstenedione. Obviously, I talk here about adults. In childhood, the 17-hydroxyprogesterone is used for targeting. But the pediatricians are obviously more professional at this because in old times, only children were seen with CAH, but due to obviously the modern treatment now, we have many more adults than children that have CAH and require care.
Thank you very much. And one last question. How much do your non-classic patients report problems with sustained exposure to heat or humidity, please? Excessive salt loss. Have you encountered that?
Yeah, the non-classic will not be affected so much. Yeah, but obviously that's important for given the location of our symposium here, of our virtual symposium. Yeah, like that's already in continental Europe the case, for example, with Italy, that if patients are either primary adrenal insufficiency or have classic CAH with both glucocorticoid and mineralocorticoid deficiency, then usually the patients get a routine increase in mineralocorticoid dose in summer. Yeah, and obviously when there is continuous heat, there might be a higher dose required anyway. That's really important. And when I was guest professor in Italy, I was astonished to find out about this. This is like sort of the difference when you are in the UK. There's not so much heat that you need to increase it. Yeah, but with non-classic CAH patients, they might require stress dose treatment of glucocorticoids, but they usually do not have mineralocorticoid deficiency.
Thank you so much, Professor Alt. Really grateful for your presentation, answering the questions. We're now going to have a short break until 7 p.m. UAE time and 3 p.m. UK time. And please don't worry about certificates. At the end, we'll have a QR code and a link that you can click and get your certificates. So you do not need to type your names or email addresses. We'll be back in less than 5 minutes. Thank you.